Group counseling offers a unique therapeutic dynamic, harnessing powerful collective forces that individual one-on-one sessions simply cannot replicate. In this setting, members discover they aren't alone in their struggles. They practice social skills in real time and confront their own denial by recognizing those same defense mechanisms in their peers. This format also stretches a limited clinical workforce across more clients while simultaneously building a shared culture of recovery. However, group is actually a family of distinct modalities. Choosing between them is a core clinical decision, driven by assessment rather than administrative convenience. The first tool in the clinical kit is the psychoeducational group. These are highly structured, content-heavy sessions used early in treatment to teach the biology of addiction and build basic motivation. The limitation here is that information alone rarely changes behavior. To be effective, these sessions eventually have to be paired with other, more active modalities. That is where skills development groups come in. These are rehearsal-based environments designed for clients in the action stage who need concrete tools for managing cravings or refusing drugs. This diagram shows the cognitive behavioral approach. It identifies a specific trigger and the resulting thinking pattern, which is then disrupted and rerouted into a new, learned response. These structured models provide the initial scaffolding for recovery, moving clients away from passive awareness and toward active behavioral adjustment. As clients progress, they often join support groups. These spaces have a looser structure, focusing on mutual encouragement and reducing the isolation of day-to-day recovery. For deeper psychological work, interpersonal process groups use the immediate relationships and conflicts happening right there in the room as the primary vehicle for change. Because these sessions dive into intense emotional territory, they require advanced leadership from the clinician and a solid baseline of emotional stability from the members. Once a client has achieved steady abstinence, relapse prevention groups help them anticipate high-risk situations and maintain their gains. Because these 6 models address distinct clinical needs, assigning a client to the wrong category risks stalling their progress or introducing psychological pressures they aren't going to handle. To understand why these groups work, we look to the mechanisms identified by psychiatrist Irvin Yalom. 2 of the most powerful forces are universality and the installation of hope. When clients realize others share their exact struggles, it reduces shame and makes the difficult work of change feel achievable. The group setting also builds self-worth. Through interpersonal learning and altruism, clients gain insight from honest feedback and discover they have the capacity to help others. This schematic shows group cohesiveness. It acts as the foundation because without this belonging and trust, members won't risk the vulnerability required for honest feedback. Understanding these mechanics allows a clinician to cultivate them deliberately, rather than leaving a group success to chance. Placing a client into one of these environments requires matching the clinical model to the individual's current phase in the treatment timeline. This timeline tracks the ideal progression. An early-stage client starts in psychoeducation. As they move to the action stage, they shift to skills and CBT, eventually transitioning to relapse prevention once they have stabilized. When this progression is ignored, the results can be counterproductive. Placing a fragile, early-stage client into an intense interpersonal process group exposes them to emotional friction they aren't ready to manage. Conversely, keeping a motivated, stable client trapped in basic education groups leads to developmental stagnation. Rigorous assessment of a client's stage of change is the dividing line between therapeutic success and clinical failure. Protecting the group environment requires strict logistical boundaries. Leaders must weigh the trade-offs of open versus closed membership and enforce clear ground rules for attendance and behavior. Confidentiality is particularly vulnerable here. Counselors must be honest with members. While the clinician is bound by privacy rules, they cannot legally guarantee the silence of other group members. Cultural background also dictates how a client engages. Individuals from cultures that prize strict privacy might initially distrust sharing their lives with strangers. A competent leader evaluates these norms around emotional expression and authority, adapting the group's composition rather than assuming a universal fit. Effective group therapy is a meticulously constructed architecture, built on precise client matching, cultivated therapeutic factors, and rigorous structural boundaries.